Welcome to the Bend Don't Break podcast. We are powered by The Source, Ben's locally owned media company and weekly newspaper. This podcast is our eddy in the rushing waters of local journalism. We are glad that you are taking some of your time to listen to us chat with the people who shape our local community. Support us through our member program at bensource.com.
Thank you to our presenting sponsor, RE/MAX Key Properties, a family-owned full-service real estate brokerage specializing in residential, luxury, commercial, new construction, and ranch and land properties. Their new state-of-the-art facility at 42 Greenwood Avenue is a modern, collaborative space and the new home of the Bend Don't Break podcast recording studio.
I'm Aaron Switzer, producer of this fine podcast with our Megan Burton as well. Co-producing, and publisher of The Source. We have with us today Holly Harris. She is an MED LPC. Did I get that right?
Sure.
And is the health service director for Deschutes County, which is really the important part. Overseeing both public and behavioral health. She moved to Oregon from Texas 15 years ago and has been with Deschutes County since 2013. Prior to her role as director, she was the manager over all crisis and forensic division services for 9 years, including the Deschutes County Stabilization Center, and later the behavioral health director. She has focused on the intersection of the criminal justice and behavioral health system for most of her career. While living in Texas, she was the director of juvenile probation for Wharton County and has worked in both rural and urban settings, serving children, adults, and families in both crisis and private practice setting. In addition, Holly has trained nationally on topics such as evidence-based practices, motivational interviewing, and risk assessments, and has been working in the behavioral health field for over 20 years. Thank you for being here, Holly.
Thank you for having me.
And I was reminded for those hardcore Bend Don't Break podcast viewers that Holly was one of the first interviews that we did because it was in 2020. We had just started the podcast in 2020, and I had started as a way to keep myself mentally active as everything was shutting down in clothing. I think the Stabilization Center had just opened.
It did.
And so a lot has changed, and I was joking that we all needed the Stabilization Center at that time.
We did. It was very busy.
So yeah, it's great to have you back, and thanks for taking the time.
Of course, thanks for having me.
And also, we apologize to all of our listeners for how long we have been gone. This is after 2 months. We're returning, so thank you for welcoming back all of listeners. The holidays and illness and all, it's crazy what can keep you from this stuff.
Absolutely.
So, well, Holly, why don't you just start by reminding viewers how you got here to Deschutes County? I don't know Wharton County. I'm
Not
sure
many
there's
people do.
a city somewhere in there, but how did you manage to end up here in little old Deschutes?
I know. It's, I never thought in a million years I would end up living in Oregon. I'm a longtime Texan, born and raised there. I had my career there, obviously overseeing a juvenile probation department. And I'm a licensed professional counselor by trade. So did lots of private practice work and other stuff around behavioral health there. Yeah. And then my sister lived up here in Bend. She worked for the Forest Service and then had babies. And then we were just coming up here all the time and really just couldn't stand it any longer. So I happened to have a job at the time that allowed me to work from anywhere. So I moved out here, and my parents retired out here, and the rest is history.
What year was that you were?
It was August of 2012 is when we moved out here. Yeah.
Okay. So you have a big role in your nieces.
Oh, yes. They were only 4 and 2 at the time,
great.
Nephews. Yeah. And
That's lovely.
And then I met my husband, and now I have a stepdaughter. And it's just, life is, this is my home now.
Yeah, that's great. Well, it sounds like you came into the mental health field kind of from the police side of things, or from that. Just how did you make that transition? And I mean, even now we can talk about this more fully. They're not separate.
No.
So how, what does that look like?
Yeah. I mean, I always thought I wanted to do traditional therapy, private practice. And so I did that right out of graduate school. And then quickly discovered that that wasn't the track I wanted to be on, and had an opportunity to oversee a juvenile probation department in a small town where I grew up, in Wharton County, which is small. Right. And they were looking to
Well, you must have had a personal relationship with some of those or known them.
Oh, yes. Yeah. And so, I mean, everybody knows everybody.
right.
town.
Yeah, that's
absolutely.
Right.
It's so true. And so the opportunity became available, and shockingly, in Texas at the time, they were actually trying to move away from a more punitive approach with juveniles and to more of a kind of restorative justice therapeutic approach. And so my background in behavioral health was enticing to them. So I went into that field not having a lot of experience in the criminal justice side of things, but really came at it from a clinical perspective and fell in love with that intersection and realized that we had more in common than we didn't.
Yeah. I'm surprised to hear that Texas was making those strides.
I know.
And probably also in Wharton County, which again, my ignorance is showing. But
no, it's true. It really was an interesting, I mean, it was more around juveniles than it was adults. Obviously, there was still a lot of kind of traditional approach with adults then. But with juveniles, they were kind of looking to really try to do something differently. And it was being led out of Austin, which was a little bit more, progressive in their thinking around that. And so it was a great opportunity and led me down a career of working in that field for 6 years.
I think that was, I mean, I remember because we were reporting on it back in the day, there was a lot of break the cycle kind of stuff. I mean, that was kind of the initiative as they had seen some stuff in early intervention with regard to education, and they were seeing the potential if you could get to these juveniles early, you'd break the cycle. Was that some of the? It
was a lot around social determinants of health, all of that, like, your experiences as a kid. If we can, if we can intervene in the generational trauma that's happening and set a different path forward, we see much better outcomes at the end of the day. I mean, we can keep investing in detention facilities and all of that, but it's much more expensive. If we can intervene sooner in a different way, we have better outcomes.
Have you been surprised as you've been in this field and starting in that path? I mean, as research has come out on, those determinants, how much the parents play in that early development role and the early lifestyle of those kids have.
Oh, absolutely.
And the impact. I mean,
that's huge.
It's so huge. And, I mean, and, nature versus nurture. And you always think that, they can, kids can grow out of those kind of environments, but it seems like increasingly I wouldn't call it a little depressing, but it's very, solid how much of who you are is set by the emotional interactions that you have at that age. What's going on in the home.
Absolutely. It's critical component of it. Doesn't mean you can't, come out of it on the other side and, your natural supports around you. There's other ways in which to navigate those unfortunate circumstances. But I think it's why programs like what we offer in public health around, Family Connects program where you intervene early when a child is an infant is entering into the home and providing the level of support to new parents who may be struggling with addiction, who may be struggling with just, life and being a new parent, having some extra support to make sure that first part of that baby's life is successful. Yeah.
I mean, I could speak from experience. It's insane when they give you that baby.
I mean, I think most families would say, like, if I had somebody there to help me through those first couple of months, for sure, it would have made a major difference.
Yeah, I remember after the first hour, I asked my wife, like, who's coming to get this? Someone else has got to have responsibility. It's not me. I know. But they're not. So,
they don't. And then imagine if you had lots of other stuff going on that you were trying to navigate.
Sure. I mean, I remember when they were talking about shaking the baby and all that stuff, and I was like, I don't even understand what that means. Like, do they get shaken? Like, what? I'm barely holding on to it. So, well, so then as you've came to Deschutes County, how did your role change from what you were doing down in Texas?
It changed quite a bit because it was such a different environment in 2012 in terms of getting a job. So I knew I wanted to work for the county because I have been a county employee for most of my career. I love working in local government. I think it's the best place you can make an effective change on the community in which you live. So I'm really a big proponent of it. So I was trying to get my foot in the door with the county, and I just couldn't get an interview. I couldn't get my foot in the door. I didn't know anybody. So I took a part-time on-call position as a mobile crisis worker. Oh, wow. So I went from being a director of juvenile probation and to that. And I was like, gosh, am I making a mistake? What have I done? But I quickly realized it was the best decision I ever made. I fell in love with crisis services. I fell in love with working for the county. And it just ended up being this step into the right pathway for me that led to the next 9 years overseeing crisis services and went from part-time on call to full-time employee to a supervisor to a manager, behavioral health director, and then somehow ended up in this role.
As the in your current role, maybe explain from, people know the services, but I really would like to try to understand you as an individual, your day-to-day in terms of managing something like this.
Yeah, so it's an interesting role. So my prior role was I oversaw all behavioral health services. And we also have my counterpart oversees all of public health services.
Okay.
So my role oversees both public health and behavioral health.
Okay.
So oversees the health department, which is comprised of, like I said, public health, behavioral health. It's also intellectual and developmental disabilities.
Okay.
And we have also an entire admin services division that supports the day-to-day, keeps the wheels on the bus, type of operation.
Sure.
So that's my job, is to really set policy for the department, work with elected officials, I keep track of legislation, budgets, really high level for the entire health department.
Yeah. Maybe just dive a little deep into behavioral services. What are the type of services that you offer at the county level?
Yeah. So at the county level, we're a safety net provider.
Right.
So it means we're going to be there when no one else is.
Yeah.
So the types of services we provide are generally like crisis services, people who are involved in the criminal justice system, people who have a significant mental health or substance use disorder, like schizophrenia, bipolar disorder, PTSD. So there's a range of mental health conditions. There's anything from mild depression to the things I just described.
Right.
So there are a lot of providers in our community that can do the traditional behavioral health treatment for depression, anxiety, things like that.
Sure.
What we offer is that intensive wraparound support to really the people who are most vulnerable and really can't get served anywhere else.
Right.
And so we serve any, youngest, little bitties, 3, 4, 5 years old, all the way to older adults, and everything in between.
Yeah. It's never something I think you can quantify, but, in terms of the number of people who need services, and it's a cloudy definition of who needs services, but as you try to provide this safety net, I can only imagine how big that net is compared to what it needs to be.
It's true.
And how do you evaluate what's being done in private practice versus what you guys can offer and what's out there that you might not even know about?
Yeah, that is a challenge, especially as we're growing.
Yeah.
I think it was a little easier when we were a smaller community and knew all of the players. I will say we are still unique in that way, though, that our partnerships and our collaborations in this county are stronger than most places I've ever seen. So we still kind of operate a little bit like a small county, and that we do generally know most of the providers. Every now and then there's a new one that comes in that takes a minute to get to be known, but we work very closely with a lot of the key providers, the bigger private practice agencies, even the one-person shops, plus Mosaic and St. Charles and some of the big providers.
Right.
We work in tandem, and we're always in communication throughout the week, regularly.
And from your vantage point, as you're looking out and the community's growing and funding's limited, and you look at this and you look at the gap, what does it mean for you in terms of trying to plan even a couple of years out?
Yeah, that's our biggest challenge right now. The biggest challenge we're facing right now is around budgets.
Yeah.
We have multiple threats to our budget right now happening both at the federal, the state, and the local level.
Right.
Medicaid is something we're heavily dependent on and is really uncertain right now for us.
Right.
So our planning, generally, we would be doing 3 to 5 year planning, innovation, visioning. What new programs are we thinking? Right now, it's about hanging on to everything we have.
The 4-month plan.
It kind of is. It's like, what do we do right now today? What are we going to do in 6 months? What do we maybe look at next year? And kind of beyond that, there's so much uncertainty that it's kind of difficult to go too much beyond that at this point.
Sure. Do you, we briefly talked about this before we began recording, about that intersection between, the housing crisis, homelessness, what your role as a mental health provider is. And maybe you can speak to that, because I know that just from cursory social media reading and what you see in the media, there's always the cliche and the thought that, you know, this homeless population, if they only had mental health services, it would go away.
Right.
And we know that's not the case.
Right.
There's a million different reasons why people, they need a roof. A roof would probably go a lot further. But so maybe explain like how do you interact with that? What's your messaging around that?
Yeah, I mean, our messaging is that we are a health department, so we're focused on the health of our community, and we have both public health and behavioral health. So on the public health side, their interventions are around, if you think about like encampments, we want to prevent disease spread.
Right.
So, we have services that are going out into camps to make sure that people are, that diseases are being tracked and caught and treated. Sure. We also do a lot of emergency planning and preparedness. So when it gets really cold or there's smoke, our public health department is working to make sure there's shelter for people who are unhoused or at least that they know where the shelter is. So that's kind of from the public health side of things. And there's lots of other areas in which we get involved on a health perspective.
Right.
Behavioral health, obviously, we have lots of clients that we serve that are unhoused.
Right.
So our focus is around treating those individuals in whatever setting they're in, helping them get to housing if that's where they're wanting to go and willing to go. And then, just providing the supports to them from a behavioral health perspective wherever we can. We do street medicine. We go out to the encampments and provide meds out there.
Yeah.
So that's our role, and also providing, we have some staff that are real experts in kind of the contributors to houselessness. And so we're at the table, but we are not an entity that can solve the housing crisis.
Right.
We don't have the authority, the resources, or the knowledge to figure out how to build affordable housing in our community.
Right.
So we're, and that gets tricky. So we're at the table, we're a part of the conversation, but it's going to take a lot of people to solve that problem.
I'm just curious if they do, like in this area, when they're doing a sweep or they're doing something where there's going to be a large disruption or there's going to be a lot of impact, and you're at the table, hearing it, and that those are the stressors, those are the things that are going to, tip the scales for a lot of people. Does it mean do you activate on that, or do you have to wait until after the dust settles or while the dust cloud is there? What does that mean for you guys?
A little bit of both. I mean, we're there to support our people that we serve. And so whatever that means, sometimes it means that if we know something's coming, we can be proactive and sort of helping them figure out what they're going to do.
Yeah.
We're primarily there for emotional support. It's really tricky for my staff because we can't make that better for them.
Right.
At the end of the day, they're going to be displaced. They still don't have a home, and they're struggling tremendously. So it's a lot for our staff to sort of bear witness to, and not be able to solve. But we can. Sometimes we are the only people in their lives that can walk alongside them through that and help them problem solve and help them get to the resources that might make it a little bit better.
Yeah. I've been sitting here trying to think of the right wording around the legislation that was passed where now in Oregon, there can be a little bit more active intervention for people who have mental health.
Oh, yes. Mm-hmm. Civil commitment.
Civil commitment.
Yes.
There it was. Yep. Has the recent legislation around civil commitment, how does that impact you? Because now you are being pulled in. You can be pulled directly in this at a third party's behest.
Well, we always have been able to be pulled in third party. The civil commitment laws, what's changed is really they've sort of, in theory, made it a little bit easier for us to intervene and force somebody involuntarily into the hospital. But I will say it's really early. Mm-hmm. And really where this stuff plays out is in appellate court, case law. So the legislation can mean one thing, but then how it gets applied in the court system and how it gets overturned in the court systems and all of that will really dictate to us what these laws mean. It's just too early to tell at this point. One area, we think it's a good thing to lessen the bar because our system in Oregon is really reactive and not very proactive.
Sure.
So we often have to wait for people to be so sick or have really terrible outcomes before we could intervene. This is, in theory, going to make that better. However, when we don't necessarily have enough resources in terms of residential capacity or treatment capacity to actually absorb if there is a bigger influx of people in that setting. So they sort of changed the law before the resources came. But, it's like,
Right.
I don't know when's the right time. I don't know.
That's kind of government.
It's just the way
That's
it goes.
what you signed up for.
Just the way it
Legislation
goes.
is coming, and they're saying, figure it out. Here we go. Do you see with civil commitment? I could see it raising the profile of individuals who might not otherwise have been on the county's radar.
Mm-hmm.
There's certainly, I would think there would be a greater need for services, which i.e. is more funding, more housing. Is that how you look at this as it starts to wind its way through? Because as they clarified, it's just kind of coming closer to you, right?
Yeah. Certainly if we start to see an influx, that will then inspire conversations around additional resources needed. I worry, though, with the budget situation at the state level and the federal level, where that money is going to come from.
Yeah.
And so it's just, we'll have to wait and see, because I don't see anybody wanting to write large checks right now. It's tight times.
Do you, what do you think is the biggest misconception out there? Not necessarily about mental health, but about the county's role in regards to the population that needs your services?
Oh, in terms of like the mental health side of things?
Yeah.
Yeah, like the biggest misconception. I think people don't understand this involuntary commitment stuff. That I think where we get probably the most frustration from families or community members is when they see somebody really ill and they want to know why the county isn't doing something about that and putting that person in the hospital. And we're sort of like, we agree.
Yeah.
We think they should be in the hospital as well.
Right.
And if we could do that, we absolutely would. But that's just tough to explain to people in terms of the laws and regulations that govern that. It's so complex and restrictive, and it doesn't, quite frankly, often make a lot of sense. And so I think that's where people think we can do more than we can.
Yeah. Well, it ends up their hands are tied, even though you can see a crisis coming. Yeah. And really, instead of having the button pre-dialed to mental health services, they have it pre-dialed for the police.
Right. Yeah. And we're really lucky here, though, at least now with our mobile crisis team that came on. We've had a mobile crisis team for 20 years. So team goes out. They used to go out with law enforcement. In 2023, we moved to a model where we go out without law enforcement, and calls that go directly to 911 that are mental health calls come directly to us.
Oh, okay.
And so we are now bypassing law enforcement, even getting many of those calls, which is huge, because now people who don't know what else to do and they just call 911 will get the right service for them, not a law enforcement officer showing up with a gun.
Yeah, I think that was part of that really bad PR push of defund the police, wasn't it? Yes. And really it was just like, let's get them direct mental health services. And I remember thinking,
exactly.
I understand what you're trying to say, but
didn't land.
you're offending people on both sides of the aisle with that one. So.
Yeah, it was true. We did have to sort of battle that. It was like, we still need police 100%. Right. In fact, even we have this model, we still need them to go with us. Sometimes it's just not safe.
Right.
And so it's a partnership. But yes, if we can get therapists out there for calls that don't need a law enforcement officer, we should do that.
Yeah. Do you So we've talked a lot about the mental health aspect of your job. Maybe speak to some of the other things you spend probably 80% of your time on.
Oh gosh, yeah. Well, right now, short session. So we're in the middle. We just started short session, fast and furious. Lots of bills. Do you
spend time with the legislators?
I'll go down and testify on bills that are related to the health department. I am in contact with our legislators when they have questions about different bills or they're proposing bills. So we have a wonderful relationship with our delegation here in Central Oregon. In fact, I would credit them with the fact that we're getting a child psychiatric facility in our region in the next year. That was direct work with our elected officials to advocate for funding for that, which came, and now we'll have that. So we do work with them. That's a lot of what I do, is trying to keep those relationships strong, make sure they understand our perspective on bills that are coming down the line, to make sure they understand the impact. Right. And thankfully they do. They do trust us, and we've got credibility with them. So that's a lot of what I'm doing right now.
Yeah, I can imagine you're busy. Do you get directly solicited from people within the community regarding the work you do with the legislators?
Not necessarily from the community. No. It's usually...
It's more just on the county's behalf.
It is. Yeah.
Yeah, I didn't know how
Yeah.
sticky that got.
Yeah, it can get sticky. And even if, we've got
Right.
processes within the county to make
Right.
sure I'm speaking, in concert with
Right.
with what the
Yeah.
county's perspective is as well.
Yeah, it's not like
Yeah.
Holly just
No,
went.
Holly just
Holly
thinks
just
that we
went
should do
off
that.
when she was up there. I don't-
Exactly.
Right. Yeah, I can imagine. What happens for you after the short session?
Yeah, after short session, we're in deep budget season. So we are
Okay.
building our budget for fiscal year 27. And right now that is all hands on deck because
Yeah.
we are looking at reductions across the board in a variety of spaces while our costs have gone up dramatically. So
Right.
we are problem solving all over the place, trying to figure out how to do the same amount of work with less, not even more with less, but just
Yeah.
trying to hang on to what we have and keep programs solid because I think as it's likely that Medicaid enrollment is going to reduce with the passage of HR 1,
Right.
we will see an impact to our budgets because of that.
Yeah. Do you think that the community? There's been so much discussion about these impacts that are
Mhm.
coming to Medicare, and there's already been the reductions to the ACA. And do you get the feeling that people in the community understand within, and I had Kat Mastrangelo on here.
Uh-huh.
We were talking about volunteers in medicine. And at the time, I think this was in November, people were not aware, and they were aware. People who are doing budgeting are certainly aware.
Yes.
People within the medical profession, I think, are very aware.
Yes.
Do you get the sense that the general community is aware of the impacts that these cuts are going to have on the community?
No, not really. I mean, I think that people that maybe track all of the stuff, maybe are more politically involved, or maybe know someone that works in healthcare,
Yes.
understand it. But your average person, I mean, I'm not sure. I mean, I'm married, and I don't know that my husband understands what's happening in Medicaid because he works
Right.
in, irrigation.
Right.
So it's
Right.
it's like your average person who doesn't live this life every day
Yeah.
is not going to understand the impacts until they start happening.
Right.
And then people are going to wonder what the heck's going on. Why can't I get, my appointment? Why can't I,
Yeah.
get access to my what happened to my insurance? I thought I was enrolled. I'm now not enrolled. What's
Yeah.
happening? So I think particularly people who are on the Oregon Health Plan who have to navigate all of these new requirements are going to struggle.
Right. Yeah, I wonder, and that's always the thing you think is that until it happens to them, they won't understand. But I've been surprised at the magnitude of the cut and that it's not reverberating more because there's a lot of stuff out there in the political discourse, and I know there's a lot of things happening on a lot of different fronts,
Right.
which has been pretty distracting. But this one kind of sticks to me as like, because it is a kitchen table topic. It's like by now people should have gotten their calculator out and been like, well, this looks like this and this looks like this. And I haven't heard it because I feel, we're in media and of course, letters to the editor and stuff. And they're focused. I mean, obviously there's a lot that people want to talk about, but I'm surprised that they're not getting down to more of the nitty gritty about their particular case.
Yeah.
It's one thing when you're talking about the federal government or the state government as an entity. Oregon's huge. America's huge.
Mhm.
But your little house is pretty small
Yeah.
and you can do that math. And I don't even have a question in there. I really am just been surprised. And when I sit down with health professionals like yourself, it just comes back to me like, oh yeah, this is going to, when do you think people will actually start to feel the impact? What's the
my guess? I mean, I think we'll all start to really feel it probably going into the next fiscal year. So July of 2027. I think, starts to hit in January of 27 is when some of the federal stuff starts to hit, but it may not play out for a couple months. So I think you'll really I think people will start to, especially if they're on the Oregon Health Plan and they now have to understand that they have to re-enroll every 6 months. And they aren't able to navigate that, or you have a family member that's not able to navigate that, and suddenly they don't have health insurance, and they suddenly can't get their medications, or they can't make their appointments, and they're going into crisis. These are the things that will start to rise up and catch people's attention. Or work requirements go into play for others. So all of that stuff next year.
What in order not to end this podcast on a down note, what are the things that you are excited about in 2026 from your perspective within the county?
Well, we do have some really exciting stuff that will not be impacted by these budget situations. And this was stuff we've been working on, but we are going to be adding a number of residential beds to our community that we haven't had in decades. So one, I was telling you about the child psychiatric facility. We have no child psychiatric facility that serves this population in our region.
What's the age?
Up to, I think this facility is up to 17.
Oh, great.
Yeah. So it's right now when a child has a psychiatric emergency that needs inpatient, they have to go over the mountain and they have to go stay in Portland. Their families have to travel and it's really hard to get into. So they often sit in our emergency department for sometimes weeks on end waiting for a bed to open up. So we're going to be adding a facility here, and that's huge. It's been decades in the making. The other thing, we're adding another residential facility for adults that's secure that will help with the civil commitment issue. Like if we do start seeing an influx, we actually will have a place where they can get treated. So that's coming online this fall of this year.
Oh, great.
And then we're adding another 2 adult foster homes that'll be kind of lower levels of care for step down out of these. So all in total, around 40 beds being added to our community. We haven't added any in the last since I've been here. And so that's huge. That will help us navigate some of these challenges. And then I just think I'm just a believer, and I guess I'm an optimist when it comes to this. But whenever you go through really tough times, like with COVID or any other tough times we've been through, there's always things you learn, and there's ways you become better, because you have to get really resourceful, and you have to collaborate and be innovative and think of ways to get through it. And you somehow come out with nuggets of things that help you be better for the long term. And I fully expect that will be the case this go around as well.
I think that's because you're a mental health professional.
That might be.
You do this for a living.
That's true.
I want some of that. I went into the wrong field. I'm only halfway to that point. Then the journalist side takes over, and we just start hammering it down. Well, Holly, thanks for coming in. Anything that we didn't touch on? I mean, we could go for hours, but
we could go for hours. No, I'm just really excited to be in this role. I'm grateful to be working for Deschutes County and living in this beautiful place, and happy to talk about the health department anytime.
Yeah, I'm gonna. Since you're in the room, I'm gonna give you all credit for getting those beds and everything, because you were at the legislature lobbying. So no credit to Anthony or Jason or anything. Right. Well, this has been the Bend Don't Break podcast. Thank you for listening. If you like what you heard, please go on the website, become a member, make a donation, and help keep supporting great interviews like this one with Holly. We're so glad you came by.
Thanks for having me.
You've been listening to the Bend Don't Break podcast, powered by The Source Weekly. To read, hear, and see more of what we do, go to bensource.com.